South African Organizing Committee for having me in front of such a distinguished audience. So this is my fourth visit to South Africa, and every time I'm charmed by its beauty. So I'm an interventional cardiologist, and mainly in complex coronary and CTO cases. Last year I've done more than 500 CTO cases only, and the rest goes on top of it. This year I've registered more than 300 cases. So I would look from a CTO and a complex PCI interventionist point of view when I talk about DEB. So we should rethink state-of-the-art revascularization procedures in complex PCI and CTO because of the 20% stent failure rate. We need better solutions. Stent underexpansion, malopposition, stent thrombosis, and free stenosis is still a problem, despite the increasing use of high-use atherectomy and intravascular lithotripsy. Another problem we are facing is the need for long-term dual antiplatelet therapy in an elderly, frail population which are prone to intracranial hemorrhage or all kinds of bleeding. So the rising interest of leaving nothing behind concept cultivates hope for DCBs. The DCB topic will be examined under 5 subheadings with the very latest publications. So the latest ACG guidelines changed its recommendation in in-stent stenosis and states that DES is recommended over DCB for treatment of in-stent stenosis. Behind this decision making lies 3 studies. The first one is the Delos meta-analysis incorporating 10 randomized trials, and in this meta-analysis, the target lesion revascularization rate at 3 years was higher with DCB treatment, while there was no difference in terms of MACE. The second evidence comes from the 10 years follow-up of ESA 3 trial, which indicates no difference between DES and DEB in in-stent stenosis in terms of MACE or target vessel revascularization. And the last one comes from a meta-analysis, another meta-analysis revealing the combined endpoint of 5 randomized trials. And the common evidence, what I got from these guidelines actually is that there is no safety concern in using DEB over DES in stent stenosis. That's actually what the guideline is telling me. And imagine this long lesion as in-stent stenosis. I give my examples from CTO cases because I'm mainly doing CTO. And who would think upfront stenting such a long lesion, considering and hoping for a moderately better target vascular revascularization rate at 3 years? First one is enough. So covering the artery with 2 metal layers of stent and damaging the artery's vasomotor function further by creating a stiff pipe is not the answer, I guess. What if we have an in-stent stenosis after 2 metal layers? Putting a third stent, is that the answer? Here, what we have done, we have, after iris interrogation, long scoring NC balloons, and preferably finishing with a NC-DEB is my latest default strategy in in-stent stenosis. If we have stenosis at 3 years again, all the options are still on the table. So what if we have stenosis in an area with overlapping 2 metal layers? What options do we have then? Again, putting the first stent, really, is that the answer? So I don't care what the guideline is recommending. If I have in-stent restenosis, proper intracoronary imaging, searching the underlying cause, preparing the lesion according to its scoring balloon, cutting balloon, IVL, whatever, and then finishing with DEB or DCB. So one should think twice before treating an in-stent restenosis with a new stent. So small vessel disease is another topic, an important topic. So although we have plenty of randomized trials, no guideline recommendation exists. We have 2022 TCT report indicates no difference between DES and DEB in terms of target lesion failure and MACE at 5 years of the RESTORE small vessel disease study. After 3 years, the Piccolo 2 trial indicates less vessel thrombosis and MACE in favor of DEB. At the bottom, each of these 2 meta-analyses investigated 5 randomized trials and concluded that less vessel thrombosis in 1 year with DEB. So this is a simulation again. This is a CTO case, and we cross the lesion. Okay, you can see it's a long lesion, maybe double CTO. We have calcification there. We cross it with a CTO wire, and after. And then what we have done is we prepare the lesion well with scoring balloons, cutting balloons. IOS is also sometimes very helpful in that sense. And then we use the 2.5 by 30 millimeter DEB balloon, not DCB. It's wrong, white put in there. So, and we use the same balloon at 3 different locations. And then we ended up like this. This was for me a technical failure. I registered this case as a technical unsuccessful procedure, both into the Progress CTO registry and into the LCTO registry. And look what happened after 40 days. So this is the beauty of the platelet cell healing effect. And after 40 days, you can see how the LAD has healed with no branchials, and you can see the distal T flow, and you can see how the distal vessel has grown. So this is sometimes what I have seen after doing DCB. This is another topic here, de novo large vessels. We have also evidence for de novo large vessels, and preserving left main from stenting in osteal lesions is also very appealing. So this is another example here. It's an elderly frail patient, 85 years old, with high bleeding risk, planned for non-cardiac surgery. Osteal LAD lesion here is the hitch here. And the iris is showing that you have an almost complete drain. It's more than 270-degree calcification. First, we have done a thorough intravascular lithotripsy, and after the intravascular lithotripsy, you can see that we have multiple cracks at 12 o'clock, at 6 o'clock, at 1 o'clock. You can after iris interrogation. And what we have done, we further prepared the artery with scoring balloons, and then we use the NCDEB. Okay, and this balloon is a unique balloon. You can use it in different areas, one balloon, and the other thing is it has an NC version, and I needed an NC version at the LAD osteum, and another thing is I had to completely cover the LAD osteum by extending into the left main. This is an 85 years old. Which drug-coated balloon you can put there for 1 minute and waiting that the drug will release into the reservoir. But this one, 30 seconds is enough. 30 seconds was enough for us. We did it 3 times, and then we left it, and I will show you the end result here. This is the final result. We have some type A, type B dissection, and this patient went into a non-cardiac surgery, and we are still following her. She's in good shape, and only 1 month DEBT. So you are antiplatelet therapy just for 1 month. So LED osteal lesions, treating LED osteal lesions further with DEB. This time, this was a very complex case. This was an ambiguous LAD CTO. We went retrogradely, and we went into first into the aorta and then into the guiding catheter, but this is not what we are talking about here. Then we have received an LAD osteal CTO and ambiguous cap. We treated it. Now we have filling there. Should we put the stent from left main and compromising the circumflex as well after such a long complex procedure, and switching and diverting the procedure to a left main bifurcation? We opted for a drug-coated balloon. Again, NC balloon because it's an osteal lesion, and we did 3 times inflation again, extending into the left main very safely. And I will show you the result here. This is how it looks after the final result. And this patient annoys me a lot because every time when I call this patient, he says to me, I want to control angiography. It has been more than 1 year now, and every time when I call this patient, he says, okay, leave me alone. Why are you calling me so often? Leave me alone, I'm good. I'm walking on the field, so I don't want to have a control angiography, but I want to see what's going on there. So this is, we have another important topic. It's the bifurcation issue. You all are doing it, I think. And bifurcation lesions represents another attractive scenario for the use of DCB. Avoiding a 2-stent strategy by applying DCB on the side branch translates into a better MACE rate in these 4 studies here. Again, I will give you an example. How I tackled this was again a CTO, sorry for that. And we crossed with the wire. And then what we have done, we prepared with the scoring balloon or cutting balloon 0.5 millimeter less than the actual vessel diameter. And then we, again, with the 275 by 30 millimeter drug eluting balloon. And then you can see we have dissection there. It's a type C, maybe it's a type B, maybe type C dissection. We have some crater going out of the vessel architecture, maybe type B, type C. And here what happens after 6 months, and you have to follow up, you can see how the vessel has grown. And of course, we are doing the measurements before and after to follow up the late movement loss. This is why we have measured it. And here comes the last topic. So this topic is my favorite intervention. These are the very latest publications indicating no difference between DES and DEB in terms of MACE, target vessel revascularization, and target lesion revascularization. So this is the Progress CTO. This is from the Progress CTO registry. The first usage in DEB and the Progress registry was in 2018. At that time, the percentage of usage was 3%. And in 2024 now, we have reached 15% of DEB DCB usage in CTO, PCI. Especially in the last 2 years, the increase is prominent. So these are the DCB scenarios in CTO, PCI. So and this is the sheet I have embedded into the Progress CTO registry. We are collecting the data and we are publishing them. And here comes the first publication from that sheet, so to say. And we have published it 3 days ago. It was published in Catheterization and Cardiovascular Intervention. And I will give some insights about that a little bit later. And then I'm writing this one here. I've outlined all the diagrams and all the figures, but still waiting for some kind of data. And then we have another study, and it's about to be registered into the clinical trial. So it's going to be the first randomized trial. So this is the latest publication that we have. So we have a better trend with only DEB approach regarding MACE in a 1-year follow-up of period. So, and the DCB coating was mainly paclitaxel, and the technical success rates and the MACE rates are not different with DES. So it is feasible, and you are preventing the patient having a pause in the future, leaving him with a stent, monopause, or for future some kind of stent thrombosis. So, do we have angiographic follow-up? So these are actually the questions that's been asked to me when I'm talking about DEB. So then we have the naysayers, okay? Everywhere we have the naysayers. They first argued against by saying we don't have evidence. So now we have some kind of evidence, okay? And now they are opposing me, saying that it's not randomized. We need randomized trials. Of course we need randomized trials. We are just about to kick off with one. And then they further oppose me. We don't have angiographic follow-up results. We will have in the randomized trial, but I can give you a taste of angiographic follow-up results. And we thank the naysayers, because without them, the scientific evolution wouldn't have come this far, I think. So, this was a live case I've done. It was, I think, 1 year ago. It was, what I'm going to show you is all complex CTO cases, not just wiring directly. So this was a retrograde case, primary retrograde case. I will not go into the detail of what we have done. Okay, I will come to the result. It was a retrograde case. And then we went into the guiding catheter retrograde with the microcatheter. I cannot see what's happening there. So, okay, so we had, okay, so we had the proximal part was dissected by the catheter, and the rest, the CTO part, the actual CTO part was treated with DEB. And it was the Protege DEB, 3 times, 1 balloon used 3 times. Another question, they're asking me, is it working 3 times? How come is it possible that 1 balloon can be used 3 times? Do you have evidence? I don't have scientific evidence, but I have my personal experience. It doesn't mean anything. I know that. Okay. But I keep going with this one because I have good results. So then let me show you what happened. This is the final result. We leave the artery like this. Okay. And then you can see after 4 months how the vessel has grown and how the side branches are flourishing. You know, and this is an acceptable result for me. And I prevented this patient from having a full metal jacket. So this is another live case. It was an Optima Life Istanbul live case. And you can see that we have double CTU, and you can see how faint the distal vessel is. I have no distal target vessel actually here. Okay, so it was again a very brutal, aggressive, retrograde approach. Okay, and we went into the guide extension with the wire, and then we did a tip-in maneuver on the left screen, on the left view that's playing now. And after that, we prepared the lesion, of course, with scoring balloons. And then we did a kissing balloon. Can we kiss 2 drug-coated balloons? This is another question that should be answered. So we don't have really evidence. We have only guys talking about DCB. But we are still accumulating data. We are still trying to understand what's going on. So what I'm showing is just my own personal experience. So this was a DEB bifurcation technique. Okay, and then this is the final result. So we had no artery. Now we have some artery. I think we have achieved something. You can see the right ventricular branch is there, and then we have the PR and the PD. For me, it was a success. This is how we left the cath lab. And on the left screen, you can see after 7 months how the vessel seems like. So we lost the PD, but we have gained another big artery that's going into the apex, you see. So for me, this is okay. So we prevented the patient, we saved the patient from a full mental check. So this is another case here. It's an ABCTO, and the antegrade approach was unsuccessful. And here we were subintimal. It was again a retrograde approach. We went from the ipsilateral, I guess, yeah, it was an ipsilateral cardia, crossing, and then we went into the typically into the myocardium, and after 2.5 scoring balloon, okay, we used Protege 2.5 3 times again, okay. So 3 times again, does it work? I don't know, maybe they gave me different balloons, it's working with me, I don't know, why it should not work. Because the balloon has a unique feature, because it's working. So this angio was done by my resident. So sorry for the bad quality of it. So now, if you take an angio, the angio machine should not pan, you should fix it. You should have it fixed, and this is the end result after 7 months. So I know you are bored. It's going to be very, very fast. So this one, we talked about dissections. You can see this is a type C dissection or type D dissection. It's a barbershop dissection, I'm not sure. And you can see here on the left screen there, we have maybe type C, type D barbershop with filling defect, with haziness in the middle. And then after 8 months, you can see how the vessel has grown. And of course, for our registry, we are doing the measurements. And at 8 months, we had only, let me show, it was 31 by 80 we left, and then it's now 35 by 30, so 3% of restenosis, so to say. This is my last example. So it was an LABCTO. Again, I used multiple times this balloon. And after 8 months, so in the middle you can see how we left the cath lab, and after 8 months you can see how the vessel has healed itself. The other thing why I use this balloon, why I am fan of this balloon is not because I'm walking with them, so because I'm an old man, So I have difficulty in bringing the balloon over the wire, So I have to touch the balloon. And if you touch another drug on the balloon, okay, then you have the drug on your hand. There is no drug left anymore. But with this balloon, you can do it. It's good for old man, DEB procedures. So if you're an old man, you can prefer it. It's also advantages. And because the drug is sealed behind the veins, it's a drug-eluting balloon. It's not a drug-coating balloon. So I will summarize it. Why DCB in situ PCI, or why DCB in complex PCI? We preserve the vasomotion effect of the artery. We are not creating a stiff pie. Okay. If you look at the IUS, if you do standing and if you look at the IUS, there is no distal systole. It's just a stiff pie. There's no systole, there's no diastole. So with DEB, we preserve the physiological vasomotion effect. Okay. And positive vessel remodeling is there with paclitaxel. With cellulose, we don't have it. So we have a transform study showing us that there is no positive remodeling with cellulose. And we avoid anatomic complications, and we are getting older and older. We want treatments to our relatives, to us, without any bleeding effect. So the EBT is just for 1 month. So thank you very much for your attention.
Thank you, Sir. That was absolutely lovely. We're going to take questions afterwards, please, directly in the tea time. As the session finishes, the speakers will be here to come and ask the questions.